talking, but they don't always, you know, take to heart that how important something is. And part of patient motivation is your belief in what you're saying, how clearly and concisely you state it, and also an important part is explaining to the patient why what they're doing isn't working. Like, yes, you brush twice a day, that's wonderful, but we're still seeing bleeding, we're still seeing inflammation. It's the whole conversation, the whole package. So be careful. One thing that can happen as a hygienist is we're used to saying the same thing, the same couple techniques over and over and over, and we start talking at our patient and not talking with them. This is what I'm seeing for you. This is the problems I am concerned about when I look at your long-term health because of bleeding. This can lead to bone loss, things like that. So it's the whole conversation, not you need to do this because I said so. It doesn't work. So this goes into, the nitty gritty of it, a little more detail, of course, but that's the gist of it. Be careful you never start talking at your patient. Do this, do that, let's move on. Why do they need to do it? Why is what they're doing not working? How is this recommendation going to help them over not just today, but the long run? So slide number 2, licensed primary healthcare provider, oral health educator, clinician, co-therapist with the patient, dentist, dental teams striving to provide preventative, educational, and therapeutic services to support the total health. So this is, the whole package. What are we trying to do? We're trying to prevent problems before they arise. We're trying to educate the patient, and we're trying to give therapeutic value to everything we do. It's going to have a benefit. We're not just doing it to make money. We're not putting crowns. Dentists don't put crowns on teeth that have no cavities and no issues. We do it because there's a reason, right? So services to support the total health. That's the reason for patient control of oral disease and the promotion of oral health. So what are the objectives? To assist the patient in acquiring the knowledge. You're going to find that many, many people are at the same level as you are, maybe not with the education background you have of, this type of brushing will cause abrasion or whatever, but they're at the same level where they know plaque and bacteria cause disease. If I keep that down, I'll have a healthier mouth. Many people, not, maybe 20% that you're going to encounter, have been brought up to believe that no matter what they do, they're going to have cavities and lose teeth anyway, so why bother? Or their mouth isn't really that important. And you're going to struggle to help them understand to come to the level you're at. If you do these things, see us regularly to remove what you can, clean differently than you're doing now, more frequently, whatever, take longer, we can help you maintain health. But you're not going to encounter every patient at the same level. So you have to understand where their level is and build on that. So to aid the patient in attaining and maintaining his or her own oral health is one of our objectives. To act as partners in their patient's oral health rather than as caretakers. Never say, I'm going to remove all this deposit and it's going to fix your problem. It will help to make things better. With the home care we're going to review, you can maintain this. Never use lingo, terminology that you take responsibility for their health. They're responsible for it. They've taken a good step by seeing you, hopefully on a regular basis. But it's not your responsibility for their health. You're going to help them by teaching them and by removing debris so they can get a new starting platform of health. The goal for the patient is a successful achievement of their own self-care, which is reflected in changes in their behavior. So if a patient has profuse bleeding and moderate interproximal plaque, something needs to change, and it needs to change for them at home. No matter how well you clean that off and you get, you know, a 5-6 day result of tissue resolution, you're not going to see them for 6 months. Hopefully you'll see them in 6 months or 4 months. If they're not chipped, you know, stepping up to the plate and then taking care, it doesn't matter how much of your heart and soul you put into that prophy to make sure it was perfect. Their home care is going to be the next step. So you have to motivate them. The dental hygienist is a primary healthcare provider of preventative services. As a specialist in oral health care, the dental hygienist is involved in all levels of prevention. So each patient requires an individualized preventative plan. If a patient has been told to floss for 20 years, reviewing the floss technique again, because they're not going to do it and they've shown they're not going to do it, is not where you need to start. Maybe you need to try soft picks or water picks or, you know, water flossers. Don't just keep the same two, you know, tools in your kit. You have to be individual for each patient. Any improvement is an improvement. Even if floss would be better, there's still stepping stones that could make it better than it is right now. Maybe they need an oral rinse to help reduce bacteria because they're not going to floss. What else can I teach this patient? So you're developing a preventative plan. The patient and all members of the dental team will work together. So how do all members of the dental team come together on this plan? You write the plan down, right? Patient has moderate bleeding today. Discussed moderate bacteria, interproximal. Reviewed water pick due to patients, you know, chooses not to floss. Tried the water pick today. Demonstrated with technique or whatever. So that's how the whole team can come together, by your documentation. So they can build on that the next visit. These are the levels of prevention. You need to know these levels. Primary, measures taken so that disease does not occur and is truly prevented. We apply fluoride, not just when somebody's showing cavities, but all patients. Hopefully we're catching patients before they get demineralization, pitted enamel, which we call incipient caries. It hasn't broke through the enamel, so we don't need to fill it. We're trying to fix that. Even before that, we're applying fluoride to try to prevent cavities. Fluoride in water, plaque and sucrose control, the discussion. Sodas, coffee with a lot of sugar can cause cavities, and sealant application, prevention. We are a major provider of preventative care, educating a child early, educating the parent even before they have children, maybe before they're even married. We're trying to get their home care is ideal, their techniques is ideal, their care about their mouth, so that when they do, if they have a family, they can pass that on to their children. Like there's never any patient that will not benefit from education. So what is secondary prevention? Measures to slow down the rate of disease. Treatment of early disease, that's those incipient cavities. They're called incipient caries, but they're still a caries, but they haven't broke through the tooth. They don't need an appointment yet for a filling, for a restoration. But if they're not reversed or slow down the progression, they will. So that's secondary. Measures related to early recognition and treatment of incipient diseases before extensive lesions develop. That's also, if you look at the last bullet on the slide, removal of subgingival calculus and debridement of the root surface. Okay, so when we're scaling and root planing, right? Scaling is removing the chunks, the bigger pieces. Root planing is the little fine bits that remain attached. You're smoothing that roughness off so that the tissue can tighten and be healthy against that tooth again. That's root planing. You are trying to get the gingiva back to health. So we have twofold: teeth, gums, bone. You know, we're trying to get it all healthy. And we know that if a patient's mouth health is healthier, their body will be healthier. So it goes hand in hand. Tertiary measures that are represented in the more complex dental and periotherapy. Prevention is still involved as long as complete breakdown and loss of function are prevented. So periodontal therapy before replacement of teeth, quadrant scalings to arrest, and there'll be bone contouring or artificial bone placed or whatever, trying to maintain the teeth with reduced bone support. Periodontal surgery does that, trying to prevent tooth loss. Orthodontic treatment before replacement of missing teeth. So tertiary, trying to get teeth upright, an ideal position for maybe a 3-unit bridge, or a patient is congenitally missing a tooth. So you're trying to create that space to put a tooth where one is never developed. That's replacement of missing teeth that either extracted or not present. So here's tertiary prevention. This patient had a full denture, and so all that's pretty extensive. We hope to catch patients long before they get to this point. So what is preventative topics in oral health? We're constantly telling the patient at the oral exam, and when you're in patient care in an office, this oral exam is like 3 minutes. You're so proficient as pulling the cheeks fully, pulling the lips fully, looking at the palate, looking at the throat, looking at each side of the tongue, floor of the mouth. I mean, that once you get it down, what you're looking for, what are the variations of normal you're going to see in all of your patients, that goes fairly quickly. Probe, spot probe, full chart if they need it. Those things will become very fast and efficient later on. Right now we're working, and we're going to take a lot of time to assess normal, but your topics in oral health, right from the beginning, when you look in the mouth and see red bulbous gingiva, is telling the patient that. You having the knowledge is not doing that patient any good if you're not discussing what you see and what your knowledge is telling you is important in what you see. I see bulbous gingiva and bleeding. If you keep in your mind this patient has inflammation that could cause bone loss, and you don't tell the patient, all your education isn't helping that patient. You might do a spectacular quad scale, but the patient has no idea why you chose to do that, because you didn't relay that to them. So right from the beginning, oral exam, you're talking about plaque, biofilm. I see incipient caries. You need to be rinsing with fluorides twice a day. We need to up maybe a prescription fluoride paste that you put on as a medicine when you go to bed. Your child or you or 18, 19 needs sealants because you're showing signs of, needing deep pits and grooves. You need protection of those. So it goes on and on. Self-screening to identify structure changes. We had a patient the other day I was discussing with a second-year student. He was 22 and his canines were equal to his incisors. And his incisors had no mamelons, and we were starting to see dentin showing through 2 of his mandibular incisors. At 22 years old, that's pretty extensive wear, occlusal wear, maybe at night, most likely at night. We needed to stop and identify structural changes. This patient needs to be considered for a night guard before the wear and tear on the teeth becomes so extreme that there's jaw issues, there's chewing issues, there's malocclusion issues, not only the physical, appearance of his arch, having short nubby teeth if it were to continue. Oral habits, nail biting, thumb sucking, children. Oh my gosh, that's a tough one, because you can get rid of a binky and just have to tolerate the crying for a couple weeks, but you can't get rid of a thumb. So when a child is thumb sucking, they're very content, very calm children, because they can calm their self. But when you go to take it away, it's a challenge for a parent. So helping them get through those steps. Sorry, my computer is being extra touchy. I don't know if you could see all the stuff clicking up on my screen every time I touched it. Nutrition and diet. We're not dietitians. We're not going to tell a diabetic how they should eat and what they should eat. What we can do is discuss crunchy foods are more cleansing than squishy foods. That would be apples and carrots. But if a patient's a diabetic, you have to say, refer to what your dietitian has recommended you eat and find the crunchier, cleansing items for your diet. And, of course, they're not eating sugars, but they need to know crackers and squishy breads and things will stick to their teeth as well and cause caries. Many people don't realize that. They think it's just sugar. But if and for younger adults, crackers and things like when you eat those little nip cheese crackers, the orange crackers with the peanut butter in them, and you chew and eat them, or eat an Oreo, and you'll see it too. But those crackers don't have any sugar to speak of. But when you smile, you got them like all stuck in your teeth and wedged at your gum line. Well, when a patient gets older and their medications are making their mouth very dry, they don't have enough minerals in their saliva. They have enough saliva to buffer those breads stuck to their teeth in that form, in that broke down form, and it will cause caries for these patients. Need for specialized care. That's why we have you measure overbite. Overjet typically does not get worse. It just is what it is. We can correct it or not. We can discuss correcting it with mom or whatever, and send to the orthodontist. It's not our job to figure out what correction they need. They should get an evaluation. But when you measure an overbite, you keep measuring an overbite through life, because if somebody has a 5 millimeter overbite, there's potential in 10 years for it to be a 7 or 20 years for it to be an 8. Overbites can get worse. And that's part of our knowledge, knowing what can deteriorate over time and why it's important to monitor. So having that discussion, I see an overbite, the dentist would be brought in on this conversation. Cosmetic dentistry, right? Prosthetics would be the replacement of a tooth. Number 30 is extracted. We have the discussion with the patient. If you have number 30 extracted and you choose to do that, rather than get the root canal and a crown, because maybe it is a savable situation, it's just expensive. And that's a real issue, expense, right? You can't just not buy groceries and pay your rent that week or your car payment. These are real issues, but a patient needs to understand before they make that choice. Number 3 could drift down into that space. Number 31 could tilt forward over the years. Your bite could start to collapse on the side. And the 3-unit bridge that we're going to recommend to replace that before all these destructive bite, scenarios happen is probably going to cost as much as that root canal and crown. So, then the patient, maybe they are deciding if it's worth the money, just get rid of it. Nobody sees that tooth. This could help them make decisions that are appropriate for them if they have all the knowledge. So this is where preventative topics, the dentist does the 3-unit bridge, the specialist does the root canal, but you're the one discussing these things with the patient the whole time you're doing the prophy. So giving them their options, explaining why these are options. This is part of your job. Blood pressure screening, we already know that, right? You guys should know that if you open the top cabinet in your DTR, your operatory, the right-hand top cabinet, and open that up, that tells you the step-by-step of the blood pressure levels. When can we treat? When do we not treat? What is the middle ground where we refer out for you know, we advise the patient they should see their physician, and we give them the numbers written down that we got today, but we can still treat. So if you ever have a blood pressure and you're considering, am I able to treat this patient? Oh my goodness, what's that number? Because if you're like me, when I'm under pressure, I can't, like, oh, was it this or that number? I get very stressed if it's like a critical right in the moment decision I need to make and it's borderline. Like, what was that line again? I'm not always 100% confident in myself without looking at black and white that's on your door. So you need to have your references available. If you don't know what a healthy blood glucose level is, an A1C blood test for a diabetic, you should have that copied in your binder, because that's something you need to know and you will encounter many, many times with our patient population. So that's part of knowing how to discuss health topics with your patient. Addictive behavior. I was looking on the ADHA board. I have one error. Let me just take a pause right now and say there's one error in your final grade determination. It said that for quizzes and for midterm, you would get the 5 points for the OHC, that like 10-page worksheet of toothbrush, floss, what are the benefits, what are this, what are that, Proxibrush, that you're going to turn in Tuesday, week 5, which is week 8 before the midterm, or the day after the midterm. You're going to turn in your worksheet to me to get your 5 points. That 5 points goes towards the midterm. You have a continuing education. Usually we just do a 1 credit because we know you're very busy. Continuing education that you're going to do online, and that gives you, if you can choose to complete it or not, that gives you 5 points towards your quiz grades. So all of your 7 quizzes, we drop the lowest, the 6 quizzes plus the 5 points CE gets added together, divided by 6. So where I was leading with that, I wanted to be sure I told you that because I realized I had that error today when I looked at your final grade calculation. I was looking on ADHA, and they have a good 1 credit tobacco cessation for hygienists. How do you discuss it? What's our goal? Because I feel the weakest in this sometimes. I was never a smoker, so I can't relate. Oh, I know how much of a struggle it is. I know it's a struggle. I see it in patients, or, you know, tobacco use. But I've not had a great background in school 35 years ago on it. How do you have the conversation? So this might, I have to talk with Ms. Smiley, but we might do this one as your CE. But even if we don't, if there's an area you feel weak or uneducated in, it's your job to pick those CEs to educate yourself. Because once you graduate and you get your RDH after your board exams, you have to maintain 24 hours of credits. And you don't, you know, you want to pick a few that definitely not just build on what you know, but help to bring in and fill the gaps of what you don't feel you know enough to give a good, you know, a good conversation with your patient. And tobacco cessation is one of them. That's a tough one. Drug and alcohol abuse, another tough one. Then there's oral safety, mouth guards and night guards, which you guys are learning to make mouth guards. Night guards would be something you would assess, like I did with the 2nd-year student with our conversation with her 22-year-old, and then you would let the dentist know, I think this patient's grinding, you know, I'm seeing this and this, and we were discussing night guards. What do you think? Because the dentist is the one who does the night guard. There are steps in a preventative program. Let me just scroll here. Assessing patients' needs, planning, select applicable preventative methods, implement, provide instructions for self-care, brushing, flossing, Proxibrush, water picks, perform clinical preventative services, right? That was slide 5 or 6, those preventative services. Evaluate changes in the patient's oral health. So when you learn the PHP, that was one of the ways you assess changes in their oral health. You have a patient, you show them all the pink. I was just disclosed by Hannah last week. And I was like, oh my gosh, I'm a really good, a conscientious flosser. I still floss in a mirror with C-shaping. And there were some spots I was missing. Like, I would have not thought I would have had pink in these areas. Not me. So let me tell you, that disclosing is seriously good stuff for motivating. You want to look carefully while the patient's laying back to see where they're missing so that when you sit them up, you're prepared to do a concise, clear, visual with this patient with their hand mirror and show them where they're missing. And then you can move on to the preventative. So while they were laying back and you were looking around, you could do a PHP and say, you're in the fair category. We have a good category and an excellent category. You're already brushing twice a day. That's most of the battle. Let's make the most out of your time and effort by modifying your techniques a little bit. And I'm going to show you how. You're always the cheerleader for your patient. You're always there to help them be the best they can be, not to tell them how bad they are, how terrible they are, but to build on what they're doing, modify it so they can be the best they can be with the time they have available to do it. And that's what this is talking about, the steps. How do you get there? Through these steps. You evaluate, you implement, you perform, and then you evaluate again. So the PHP is meant to be done in 2 visits. So if Hannah had me as a full patient, she would have sat me up and said, see where you're missing here and here? Let's just see if you can curve that more to get that. And let's see if that's enough to do it, or do we need to think about another tool? Maybe I'm not able to curve my finger enough to get that area because of cheek in the way or tight cheeks or something. So she would try herself to see if it's possible. And then she'd let me do it to see if I'm able to, and not assume this is where we stop. Maybe we need another tool to help this area. And then she would say, well, I'm going to see you back. Maybe for me, it would be 6 months if we were in an office and it was a once and done. And we're going to look again and see if these have worked. And she would do a PHP again to see if I was in the good or fair category. So the PHP for you guys is awesome because you see patients 2 or 3 times just to complete a prophy, probably 3 or 4 right now. So when you do the PHP at visit 2, and then you scale and polish and you've given them home care and you bring them back for visit 3 and you PHP again, you can show them how much better they're doing. And then they are invested. What I did worked. It wasn't that hard to do. It really only took another minute of my day. I can do that. You're helping them establish their long-term goals. So here were the steps: assess, plan, implement, perform, evaluate. Now these slides are going to go step by step with this slide 14. All of those are broken down. So assess. You guys know how to do this. You need to identify predisposing factors. What if you have a patient who's on Dilantin or a high blood pressure med that causes tissue overgrowth, which some do? You have to know that. You can't just be like, what's going on with you? What are you doing wrong? You have to be able to identify predisposing factors. What if you have a type 2 diabetic whose A1C is 7.5 to 8? That's not healthy. That is not going to allow the patient to resist bacteria. They're going to break down and have bone loss, mobility, and disease. So that's important, knowing your background, paying attention to it. If you start to forget it, reviewing it. Bullet 3, utilize your indices. We talked about that. Assess patients' willingness and readiness to learn. I never, ever take a patient's huffy, puffy, don't care mood to not do patient ed. I may modify it if they're not in a good place that day. They're having a rough time with life in general. like they can't hardly take anymore. I will modify what they're doing. I will discuss what they need to do, but maybe the conversation isn't as long that day. But I never not discuss home care and what they need to do because it's their responsibility. And sometimes you have to take, sometimes you have to repeat things 4 or 5 visits. It could be 2 or 3 years down the road, and a patient will finally be in a place to say, I've heard this multiple times, maybe I should start doing it. Okay, so you have to be careful that you are always assessing and never not doing something. But you do have to understand, if I just had my twins and I scraped myself out of my, sweatpants after getting 4 hours of sleep for 2 months straight, but I didn't want to miss my dental appointment. Maybe this isn't the day. I need the full, full discussion of this, that, and the other. Just tell me I'm not doing good. My plaques everywhere. I know, gosh, you must be so tired, Linda. Here, you need to work harder here and here, and let's maybe see you back in 4 months because, you don't have time right now. And I'm seeing a lot of plaque and bleeding. How about we see you in 4 months so we can reassess this? Maybe right then I don't need the full brush, floss, Proxibrush discussion because I just don't, I don't have time in my life. So you have to know where people are in their life. Sometimes you have an elderly person and a spouse just passed away, right? Or they're very ill, or they're taking care of somebody with dementia. So you still have to assess their needs, but you need to understand their readiness to learn that day. It's not always where you want it to be. Plan for intervention. Apply general information about the patient as it relates to oral health. We talked about, if you remember, 111, in Dover, some dental offices have a heavier than most offices through the state of the Amish community. Their cultural background is more self-help, more herbal, more, not go running to the dentist every time they have a little toothache or pain, actually avoiding the dentist more times than not, and only coming when absolutely necessary. So you have to understand that cultural influence. You can't put them on the same discussion as you would somebody who comes every 6 months and values the dentist and values, this interaction. So you have to understand that. And if you don't understand that, maybe you need to learn more about their background. Patients' attitudes, right? I had a patient that was a real struggle for me. I was just out of hygiene school. She was in her early 40s, I would say. Beautiful teeth. As soon as and I told you the story before, as soon as she would get a cavity, she was like, just pull it. And she had multiple teeth pulled because she was adamant she wanted to have it pulled. She still had to get the anesthesia. There was still trauma going on to the mouth, much more than just a little quick drill and fill, rocking a tooth out of its socket with a normal bone height. I just couldn't fathom it. But I kept trying to educate her why she should save these teeth. It didn't help, but at least I knew I did all I could. But I still had to deal with her attitude, where she was at in her mental place. Education level, right? Not every patient has had education in healthcare for their self. They may not have even had availability to healthcare from the time they were 4 years old, like my children have. And if, Melissa's children have probably had, but my parents certainly did not. My mom had all of her teeth pulled. My dad had most of his teeth pulled while they were in their 20s. Can you imagine at your age not having teeth or most of your teeth pulled? But that was their education level. That was the time they were in. That was their environment that they grew up in. And there are plenty of people my mom and dad's age with all their teeth. But in the very, very, at the time, rural area they lived in, the dentist availability they had, the money they had to go to the dentist to be educated, and maybe the dentist attitude, because he was old at the time, so he graduated in 18 or 1920 from dental school, right? My parents were born in the 1940s. So his mentality was just get dentures. You're going to lose your teeth anyway. And that was my parents' mentality. So you're going to still encounter people who have not had preventative education and they're in their 20s or 30s for different reasons. And you have to start at ground zero, like you did the 4 and 6-year-old. Occupation. Is a patient a boxer? They're getting teeth knocked out? Maybe what are they doing? Are they in a type of field where they're exposed to metals? You learned in Miss Myers, I'm sure, about metal incorporation into the teeth as it's developing, all of that thing. So, that's rare, of course, but understanding a patient's occupation, plan for intervention, applicable preventative methods, assess time. Again, if you'd gone in, if I was not a flosser, knew nothing about flossing, or didn't care to have learned it before I showed up for my dental appointment, and I've got twins that are 8 weeks old, that was probably not the time to discuss full-on flossing with me with technique, because I wasn't going to implement it. It may be in 6 months or 4 months you should do that when I had more sleep. So that, that's just a general reference, but assessing somebody's time. As the hygienist, they still should have told me you need to floss. If I was a general patient, not a hygienist, and was not flossing, you need to floss. I'm seeing a lot of inflammation and bleeding, but maybe right at that moment was not the time to do the full floss descriptor. Maybe just improve my brushing and make a good note to the hygienist, to herself or himself, to do flossing next visit. Skill and dexterity, right? You're not going to go into wrapping the floss around middle fingers and flossing if your patient has extreme rheumatoid arthritis in their fingers and hands, or they can't lift their arm because of a shoulder problem. So you need to assess the patient. That's part of assessing the patient as they come in. Just don't head straight for the mouth. And preferences. That's the patient who's been told to floss for 20 years, they're still not flossing, move on. Move on. You need to discuss something else. Recognize the influence of age and physical and mental abilities. Applicable preventative methods. Patient's current methods, care and frequency. Always build on what they're doing. Perfect that first. They're already doing it. Let's tell them we can help them make better use of their time and efforts by tweaking it a little this way, little that way. Slow down on this tooth. That's harder to get because it's very round. Tell them why they're struggling to get a tooth, because of the linguoversion or buccoversion or shape. They have to slow down here for this area. A lot of times that's all they need. Tell me why. Why I'm brushing it just like I do up here. Why is down here not getting clean? Why is this section you're always fussing? You need to assess it. You need to fit the brush and figure out why it's a struggle, and then show the patient how to do it. You're discussing the goals and the measures required to meet the patient's goals. You may need to brush for 2 whole minutes. The brushing you're doing the technique is fine, but you're not doing it long enough. And I have a lot of patients who come in over the years and they have no plaque, but there's profuse bleeding. They don't have any plaque interproximal, they don't have any plaque buccal and lingual, and I'll say, your techniques are marvelous. You need to do them every day, because they did them right before the appointment and not every day. You could just tell. Eventually you can tell. And if there were calculus buildup, that would be the obvious indicator. No plaque, but calculus. They weren't getting it before. They brushed or flossed thoroughly right before your appointment. So your techniques are great. Let's build on doing it every day, twice a day, whatever. And select applicable preventative methods, right? Maybe a patient has high acidic level. Maybe they have GERD and their oral cavity is going to be acidic because of the reflux. This might be the patient who needs a prescriptive toothpaste, and those prescription toothpaste, put a little on your finger and you rub it over your teeth after cleaning them and before bed, so that you don't eat or drink anything afterwards. and you saturate the oral cavity with a high strength fluoride. Maybe your patient has extreme dry mouth and root exposure. Caries is going to be extreme for this patient. So understanding what preventative methods a patient needs. Explain potential consequences if a patient does not follow the care plan. I'm giving you this prescription paste because of all of these incipient, these baby caries that could become large cavities that need to be filled. We want to prevent that. And this is how we're going to do it. Explain the consequences. If we don't prevent it, you're going to need lots of fillings. You're going to have holes in your teeth that are cavities, right? So not just you need to do this, why? And what are the consequences if they don't do it? That's the whole package that motivates people. Select applicable preventative methods. Having a plan. Use the time effectively, efficiently. Help them learn from the simpler to the more complex, building on what they're doing and then add to it. We have 10 minutes left and then we're going to take a break. Planned patient learning. So remember slide 14 are all of these steps. So these are all those, 5, 6, I can't remember, bullets broken down. So when you're studying, go to slide 14, and that had all of these, the assess, the plan. That's going to be your guide for all of these things. So planned patient learning objectives, preparation, presentation, demonstration, practice, and evaluation. So what the objectives, why am I showing you this? Preparation, what do we need to have? We need to have floss string. Let me give that to you. We need to have fluoride rinse. I have a sample. Let me start you out so you can go right to the drugstore and get a bigger bottle. Presentation. Let me show you these little pitted areas, right? Look, this is when I dry this. See how that's chalky and pitted? That's an early sign of a cavity forming. Demonstration. You're going to apply this prescription fluoride, and you can use just regular toothpaste to show them how they're going to do it so that when they go to the drugstore, they know. Let me put this on my gloved finger and I'll rub it across the buckles of your teeth near the gum line on the roots. Show them how simple it is, what they need to do, how much they need, right? Practice. If it's a flossing technique, you practice on the dentiform to show them. They try it on the dentiform so you can discuss the technique, and then they go to their mouth, or actually you go to your mouth and you show them what it should look like, slipping under the gum with a C-shaped curve, 3 times up and down each side of each tooth. And then you say, now let me see you try it while I hold the mirror for you. Because trust me, it looks so simple when you do it, and then they go to do it and they're like this, like, I don't know what to do. And you can help guide them. So when they get home, they're not doing this going, I can't do this. They practice it in front of you, with you, and you evaluate how to help them perfect their technique. So your objectives relate realistically to individual needs, interest, and ability level. Right? We've built on that. All those conversations I've been having with you up to this point are what that bullet's talking about. Your objectives should focus on the improvement of oral health, reduce the potential for new caries, eliminate, control, and/or prevent gingival and perioral infections. And another bullet should be added to this, having the conversation. You have type 2 diabetes, you have a heart condition. The chronic inflammation in your mouth has been shown to cause the body to be struggling with this inflammation, and it could cause the other inflammation to become worse. That could make your other health issues worse. So, there's pamphlets on that from ADA. If you don't have those in your office when you get started, you should, because it's a motivator. And it's knowledge the patient needs to know. Preparation, patient-centered. Of course, we're their cheerleaders. We want them to be healthy. We don't want to be frustrated when they come in and they have all the stuff everywhere. It's not just your day that's being affected, it's their health. So we're preparing for that patient. Customized according to oral conditions, should relate to all domains of learning. Effective, you address attitudes and interests. Cognitive, their knowledge, what level are you starting at? How much preventative discussion have they even had in their past? And what are their motor skills? So when is the best time during the appointment for patient education? Initial instruction should be given first before any clinical treatment. In other words, before you scale all that moderate plaque off between their teeth, you should show them. And if you can show them with disclosing, trust me, I'm a believer, how much that's like, whoa, how'd all that paint get there? That's ideal. And then you continue the education and reinforcement throughout the appointment. That's the ideal. Patient education is ongoing. Sometimes I don't even realize until I start scaling that a patient has a pocket of food debris. Even though I kind of explored around, I wasn't maybe really getting my Explorer hooked in some meat debris between 14 and 15. Like, oh my goodness, this is quite the impaction site here. We need to address this because you could have rapid bone loss due to this excessive food impaction site. They have some type of diastema occurring as they chew that's allowing for an impaction. So it's usually best to give instructions early, prior to clinical treatment, because it shows emphasis on self-care. In other words, it's not an afterthought. It's not, oh, we always discuss this, let's get it done while we're waiting for the dentist. You put it first, you're showing how valuable, how valued you feel this is as part of their health, and home care is an important part of that, just as much as the scaling you're going to provide. Biofilm is visible to the patient, and the patient's more receptive because they're not tired and sensitive and just, oh my gosh, I've got an appointment. Are we running late, right? If you've been in healthcare, you know that patients come in and they have very little time sometimes. They're squeezing you in before they've got to get somewhere else. They got to do somewhere else. They got to pick up a child. They got to get back to work. So if you're doing home care early, they're not like, I'm running out of time here. We'll have to do this later. And if they're tender and sensitive, trust me, they've shut you out because their mouth is hurting, because they didn't take care of their mouth in the first place. Their gums are tender, or they have root sensitivity, and they're just still trying to overcome that mini trauma they just had because of the issues with their mouth, not because of your inadequate technique. I'm sure there won't be that issue. So that's not a good time to discuss those things with patients. That's why early in the appointment. Closed questions are yes or no answers, 1 or 2 word responses. We're talking about what types of questions. Open-ended are the preferred questions. What kind of preferred? The yes or no, or the open-ended? The open-ended. It requires more than 1 word response from your patient, and it allows the patient to express opinions and ideas. So that's something you should always strive to have open-ended. And you have to be careful with that with medical history. You try really hard, and I struggle with this sometimes. You try really hard to say, have you had any medical changes or issues or hospitalizations since I saw you last? And you've already reviewed their health history, but sometimes as you're picking it up, you're asking them, because they're like, oh my gosh, yeah, I was in the hospital, had chronic, pneumonia with COPD. And I'm like, well, are you on an inhaler? Because you didn't list that. And let me write that hospitalization down because I need to know you have some breathing issues. Because if I want to use the ultrasonic scaler, I might not be able to on this patient. They've got breathing issues, right? That they forgot to mention because they feel so much better, thank God. So they've kind of put it in their past and they're trying to forget about it. You don't want to say, you haven't had any issues, have you? Because they're going to want to say, oh no, I'm good, right? The open-ended allows them to reflect a little bit to give you a full sentence answer And they might come out with things they wouldn't have if you led them with a yes or no question. So when communicating during patient ed, it's most effective to use open-ended. What do you currently do for care of your mouth? Instead of saying, do you floss? And they'll be yes or no. Then you don't know if they're doing anything else. You didn't give them the opportunity to say, I use an electric toothbrush for 2 minutes and I spend a lot of time. Maybe that's the place you need to start, but you don't know, and you're showing the old manual brush because you didn't give them the chance. You asked them a yes or no question. What do you know about periodontal disease? If they're like, what is that? I don't know. You know where you need to start. A lot of times we wouldn't say caries, we would say cavities, because a patient, even the well-educated patient, isn't always clear on what caries is, but they know what a cavity is most of the time. Next bullet, what concerns do you have about treating the infection in your mouth? And what other questions can I answer for you? I always start my appointment with, do you have any problems with your teeth or gums today? Because many times a patient will have an issue, but they're like, oh, I have this prophy coming up. I'll wait and tell them then. And then we get going with our spiel and they forget to tell you because they were waiting for that window that never happened. So I always start my appointment with a patient. Do you have any problems with your teeth or gums today or since I saw you last? After the medical history question, have you had any hospitalizations or issues since your last appointment? Right? 2 open-ended questions right from the get-go. And the patient can think. They raced from an appointment to get here and they may have forgot they had that really sensitive tooth that when they ate hot and cold and bit on something, gave them a searing pain 2 or 3 times. Give me 1 second to finish my soapbox and then we'll take a break. And you know, it happened periodically, but it wasn't happening today. And they forgot, oh gosh, yeah, that's right. They may have a tooth fracture you need to know about, but you got to give them the chance to think for a second so they can tell you that. Okay, well, let's take let's set our timers for about 8 minutes. That should give everybody time to get back, get a little break, little drink, and then we'll start back in 8 minutes. Okay.